It's my honor to present Dr. Waseem Ahmad, one of our wonderful GI faculty at UCSF. He earned his MD at Rush Medical College, then completed residency in internal medicine and fellowship in GI at University of California, San Diego, where he also served as chief fellow. He came to us in 2022 when our class was in our first year, and quickly became beloved amongst the fellows. He's passionate about teaching in an efficient, high yield and evidence-based manner, and I personally have learned so much from his expertise in GI topics, ranging from the myriad of disorders of gut-brain interaction to how to approach non-IBD causes of diarrhea, which he will teach us more about today. So with that, I will let you take it away.
All right. Thanks, Donna, and thanks everybody for joining. I know it's always a pleasure to have all the fellows with me, both in clinic and endoscopy. And one of the common things that you'll see rotating through general GI clinic are conditions of diarrhea, bloating, constipation, abdominal pain, and sometimes it can be very challenging. How do you take someone's months to years of symptoms and consolidate that, tease through it, and really have an efficient way of getting down to what is the most likely thing going on and ultimately how to get a patient feeling better. And so hopefully after this talk, we kind of develop a framework about going through this manner. I have no disclosures. And so the goal of this talk, like I said, is to create a roadmap to working through chronic diarrhea. We'll go over best clinical practices. And then at the end, we'll go over certain disease states that we see more commonly, including IBS diarrhea, microscopic colitis, and bile acid diarrhea. All right, so just to start off with a roadmap, a lot of general GI can really be focused on a very concise history. And by concise, if you can get yes, no, or just a little detail on each of these questions, it makes it a lot easier in terms of knowing, is this something that is concerning, not concerning, and then also trying to essentially bucket someone in terms of what could be going on. For example, when you just start off with demographics, if I get someone that's young versus older, my suspicion for something like IBD versus microscopic colitis may change. Getting an idea about someone's stool, what is the frequency? What does the stool look like? A lot of times people, when they comment that they're having diarrhea or loose stool, they actually don't have diarrhea. They may actually be having just incontinence or, concern for overflow. Getting an idea of stool consistency, whether it's watery, fatty, bloody, that's going to tell us a lot about, where exactly we think things are going on. Periodicity and pattern of symptoms. And so I think we do a good job about this when it comes to abdominal pain. When did it start? What's provoking? What's palliative? We can do the same thing when it comes to diarrhea, recognizing that, the pattern of someone's stools and, relationship to certain things like diet or stress or, other factors can sometimes give us a better clue of what's going on. And with that, trying to tease out when exactly this started. I often ask a few, common questions to all my patients, and it gives me a good glimpse about, okay, where is this patient coming from in terms of can they pinpoint where exactly their symptoms started? So, a good question to ask someone in clinic is, can you walk me back to a point where you felt completely normal about your GI health, that you didn't even have to think about your GI symptoms? Usually people can kind of remember when they were feeling okay. And then at that point where things started going, sour, you may be able to tease out, oh yeah, I went on a trip here, or I caught a GI bug there. And it kind of changes, okay, is this something that is more like post-infectious IBS or SIBO versus somebody who might have more a concerning history that this all started after I had my gallbladder removed or after I got radiation. That gives me a different glimpse about what could be going on. Associated symptoms, review systems in GI clinics sometimes can be very focused and other times can kind of give us a better idea if there is something concerning going on. Trying to notice, are there red flag signs or symptoms? Is there GI bleeding? Is there unintended weight loss? Is someone having episodes of or concern for malnutrition? that's going to change, my concern for this patient when it comes to the diagnostic workup and then also what can be going on. Medication history, I encourage everyone to take a very quick look through someone's medications. In GI, often we're going to get patients that are, second referrals or consultations, and they're on many medications. And it's very important to know the side effects of a lot of these medications. And, we'll go into a little more detail, especially when it comes to microscopic colitis, that, some of these medications and the time course from when they got started to when they develop symptoms can give you an idea about what could be going on. And that may change, how aggressive you need to be with diagnostic workup. Prior surgeries, radiation, this is always part of my initial intake. And so before I start with any patient in clinic and try to get, their input about, what could be going on, I make sure I kind of check off like the easy things, prior family history of GI malignancies or IBD. And then I follow this up with prior abdominal surgeries and including that with radiation therapy. Because if I know someone's had a big abdominal surgery or has had radiation and I can figure out the time course, then potentially that's going to impact, my next steps, whether it comes to imaging or doing procedures. The last part is we should definitely not forget our medicine hat. There are a lot of systemic conditions, especially, autoimmune, immunological, cancer, that these things can tie into one another. And so knowing if someone's had, cancer in the past or on immunotherapy, that's going to change my input than say someone who's otherwise young and healthy. The last part here, and I think this is very important for any patient that we see in general GI clinic, including for diarrhea, is what is the impact on your quality of life? A lot of people really are not going to see a gastroenterologist until they start having symptoms. It's not something that is, something you're going to really talk about with your friends or family unless, something was very serious. But, for a lot of these patients, they are having symptoms that are, sometimes difficult to talk about. It is affecting, their day to day, whether it's socializing, every meal that they eat, it's, making almost a life and death type of decision about what can I eat, what can I not eat, can I go exercise? And so just asking, how much of an impact this is having and, trying to tease out, okay, well, you've had these symptoms for so long. What is something that we can work on over these next 2 months, 3 months that will get you feeling better? And I feel like if you develop this at the initial visit, you get good patient rapport. And the second you start getting some input there, I think it kind of is almost like a feedback loop where both us and the patient feel good that we're in the right direction. So, this slide is about physical findings and chronic diarrhea. The main thing is, yes, there are going to be tons of zebras that you will see over the course of your fellowship and in practice. And obviously, we've learned many throughout medical school. I think, the big thing is always keep the medicine hat on, especially if something isn't lining up with, the typical things that we see. I would say in general, the big things that, we would be cognizant of more, commonly are any episodes of malnutrition. So example, muscle wasting or peripheral edema. And then also on the bottom when it comes to fecal incontinence. So again, a lot of people will not be able to tease out what is the difference between incontinence and diarrhea. And so if you see a patient in clinic or on the consult service, doing a rectal exam can be important and just get an idea about the anal sphincter weakness, so rectal tone, because that might change. Is this someone that we need to be managing from an antidiarrheal standpoint, or is this someone that we need to send to pelvic PT and biofeedback therapy? Conditions that we're going to hopefully be able to get a better idea about how to manage, or at least try to bucket them over the course of this talk will include bile acid diarrhea, carbohydrate malabsorption, different iatrogenic causes, IBS, microscopic colitis, EPI, SIBO. And as you can see, there's lots of different things that are on the table, and it's really about coming up with a way to kind of bucket these things to make your diagnoses a little easier to figure out. So just to start off, if there is kind of a roadmap, where is the initial branch point? So, the first thing is, okay, does somebody really have chronic diarrhea? And that essentially is defined as having loose stools for over 4 weeks. The easiest things are, can you check off, okay, is this actually diarrhea? And then are there other things that are more of a yes, no that can be explaining someone's symptoms? So, for example, if someone has fecal incontinence, that's going to change our diagnostic workup considerably compared to the more common diarrhea conditions. Next, iatrogenic diarrhea, like we talked about, certain medications, surgery, radiation. These things are all very important in terms of, if you can get these off the table, then you can start focusing more on the nitty-gritty of someone's symptoms. And then I would say the third big thing that is easy to kind of check off are chronic infections. So, bacteria, parasitic infections. Oftentimes, by the time someone sees us in clinic, someone's already had, stool workup and these have been ruled out. For most of us, when we get the chronic diarrhea consults, it's mostly group 4 and group 5, which is patients that have kind of a mix of different types of symptoms. They've been ruled out for infection. There isn't anything obvious, at least on the initial kind of workup about what could be going on. And from our end, doing the detective work. Is this IBS-D versus SIBO versus bile acid diarrhea? Is this, something more concerning? When it comes to, okay, how much of a diagnostic workup do we need to do, at least right off the bat? And we'll go into this a little bit later when we get into best clinical practices, is, lab testing wise, at least getting an initial CBC, CMP, just making sure there's no crazy lab abnormalities. When we go through the IBS kind of guidelines, making sure someone has a TTG, calprotectin, oftentimes if someone already has a CRP, that can be helpful. Infectious stool test, if they have not already been ordered, is important to have. Imaging and colonoscopy, we'll talk about a little further about maybe who do we push for scoping versus maybe monitoring. Same thing with imaging. In general, if this is someone you're concerned for something structural or someone that's had prior radiation or surgery or there's a question about, pancreas being involved, I think these are some things that you might push for imaging a little bit sooner. The last part, if you were to separate stool into, oh, is it osmotic or secretory or steatorrhea, that also is a different way of trying to think about these patients in terms of, okay, what is the mechanism that is driving someone's stool? So if you want to just break up diarrhea in these aspects, osmotic diarrhea, usually something is being ingested and it's going into the lumen of the colon. And essentially because of that increase in osmotic load, you end up having diarrhea. These are the patients that are, taking excess either carbohydrates or sugar alcohols or taking, extra laxatives. Most patients that we're going to see are going to fall into group 2 or 3 or secretory diarrhea or steatorrhea. So secretory diarrhea, common conditions of microscopic colitis, celiac disease, SIBO, different kind of more systemic conditions. And then with steatorrhea, whether it's maldigestion or malabsorption, examples would be SIBO or EPI. A lot of things when it comes to diarrhea, you have to tease out what's going on in the proximal small bowel, because this is where a lot of the nutrient and vitamins are being absorbed. And if there's any issue with the local environment when it comes to, say, SIBO or the release of pancreatic enzymes, that's going to affect whether this person is having loose stools or not, and then also the consistency of stools. On the bottom, we'll kind of go through some of the diagnostic testing that goes with each of these. So with that, we'll go into best clinical practices. Towards the end, I'm more than happy to take questions or kind of go about like how to think about each of these things. So when it comes to best clinical practices, there's not a, for a lot of conditions, we have great ACG guidelines, AGA guidelines that can help us figure out which way to go. With diarrhea, there isn't as great of evidence compared to some things that are a little more concrete. And so this article from Schiller and CGH is kind of the framework article that we go by. When we go into IBS diarrhea, there is a little bit more data about what to do. And so I think these questions, as well as the recommendation level, can kind of give us input about, okay, how strongly should we follow these versus is this more of a case-by-case basis? So to start off, how is chronic diarrhea defined? So patients need to have loose stools for greater than 4 weeks. And so, if you get someone that's just noticed loose stool for the last week or so, that's not going to meet that definition. The same thing, trying to tease out incontinence versus diarrhea is important. And so, again, if you want to think about branch point, that's the easiest first place to start. On the right side, we'll talk about IBS diarrhea in a little more detail and about what goes into both management and diagnostics. I think the big thing here when it comes to recommendations is if someone has alarm features, unintended weight loss, GI bleeding, something's not adding up, that this is a little more functional in nature. That's someone that, the light bulb should go on, that maybe you need to do a little more an aggressive workup rather than maybe a more non-invasive workup approach. What is the role of diet when it comes to chronic diarrhea? We get this question a lot. Almost every patient is going to ask about diet in some nature. And, sometimes it's very extensive and it can be, a little tough to get everything done in, one clinic visit. But I think some easy things to start off with are just trying to tease out, is there something that you eat or drink that kind of aggravates your symptoms? I see a lot of people, especially as they get older, they're going to have issues with, alcohol or onion and garlic or a lot of the FODMAP foods. But if you can tease out or have the patient almost keep a food diary by themselves, they may be able to solve their issue even before that they see you. One thing of note, sometimes you'll get patients that ask about food allergies. Number one, we don't really have great diagnostic testing for whether someone has food sensitivities or not. But number two, a lot of these patients have been having, loose stools for quite a while. The chance that they have a true allergy is very, very low. And so it's something that, you need to recognize and, discuss with the patient that, yes, there could be a contributor that it can aggravate symptoms, but let's look into other causes that could be going on. What medications are common? We'll go over on the next slide, some things that we definitely need to keep in mind. So like I said, for diet, easy ones to kind of check off, at least at our clinic visits, things on the FODMAP diet, especially if they've tried it or not. Artificial sweeteners, people that eat a lot of chewing gum or soft drinks, caffeine and alcohol are also kind of easy ones. Sometimes people will ask, well, what should we do about diet? How aggressive to be about diet? When I encourage people to go on low FODMAP diet, I definitely don't push for it in the beginning. What I'll do is I will give kind of instructions and the handout when it comes to what goes into a low FODMAP diet. And I just encourage patients to just look it over. You don't have to do anything. It's a very overwhelming, restrictive diet. If you wanted to try it yourself, you can imagine it's going from, 60 down to 0, and it'll be very frustrating off the bat. And people are gonna, after a week or two, quit, and then they feel that nothing is getting better. Instead, encouraging them to just take a look at the list, see if there's one thing on there that you eat a lot of, and then just try cutting it out for a week or two. And then if it helps, great, maybe we're on the right track. And if it doesn't help, well, we'll go back to the drawing board and find something else on that list. That way you're working hand in hand with the patient, and the patient is also taking charge of their care as well. When it comes to medications, NSAIDs, antibiotics, magnesium supplements, these are some of the more common things we have to keep in mind. And again, we'll go in later on about different medications that go with microscopic colitis. What other therapies can cause chronic diarrhea? Again, I think it's very important to ask about radiation and to also ask about abdominal surgeries. if someone's had radiation for, say, prostate cancer and they come in with, hematochezia, easy for us to think, okay, this patient probably has radiation proctitis. But what might be a little more challenging is if someone got, radiation therapy and comes in 3, 4 months later with maybe some tenesmus, some urgency, and they have some lower abdominal cramping. The question is this radiation induced or is this, say IBS? And so knowing that radiation is on the table can at least help us when it comes to our differential. Abdominal surgery, I encourage everyone, if they've had any type of surgery, is to get an idea about number one, when was it? And then number two, if you can get the op note, it's very helpful. So if someone's had a big bowel surgery, how much of their small bowel is gone? Is this person at risk of short gut? If they've had their colon removed, which part of their colon was removed. They've had their gallbladder removed. That's important. If they've had a different type of bariatric surgery, like a Roux-en-Y gastric bypass, now do we have to think about dumping syndrome or, it's very important when it comes to abdominal surgery, how much it impacts us in terms of, what could be going on for patients. And then also, just for practice, say you never want to go into an endoscopy or colonoscopy blind. And so knowing what anatomy you're getting yourself into can also impact, okay, what is your strategy when it comes to thinking about the pathologies that can be going on? I think we do a good job about this on inpatient when it comes to, say, hemostasis or GI bleeding cases. But using the same approach when it comes to different GI pathologies can be helpful. What diagnostic testing is indicated? We'll talk about this a little further. Everyone's going to be a little bit different. How aggressive do you need to be with stool testing or lab testing, imaging versus procedures? And again, this is kind of sometimes it's going to be based on alarm symptoms. Sometimes it's going to be based on, already the workup someone's had previously. And you can see these are 2C recommendations. But we'll kind of go over what are some testing that you could reasonably do off the get-go versus some that, dependent on the patient that you may be able to skip. So first off, when it comes to stool testing, is there any benefit of categorizing the diarrhea by stool testing? So in general, this kind of falls in, kind of 2C, 2B recommendations. I would say when it comes to stool testing, infectious stool tests, if they haven't been done, you should get those. A lot of times people have already gotten a fecal elastase, and if it's low, then the question is what to do. And we'll talk a little later about, EPI and whether that's something, how aggressive a workup we need to do. Fecal calprotectin, I think, is a good one for us. We often will do that for IBD. You're going to see more and more eosinophilic GI disorders, and you can almost use calprotectin as a, kind of a surrogate biomarker for that condition as well. Whether you're going to do stool osms or fecal fat, I think that's kind of maybe the threshold about, all right, how much do you chase versus kind of doing other diagnostic tests that might be a little bit easier for not only you, but the patient as well. What is the utility of blood test? In general, it's not going to be too helpful. Obviously, someone's probably had a CBC or CMP. If they're on the inpatient setting and they have a big electrolyte derangements, that might give an indication of maybe kind of a big, secretory type diarrhea or malnutrition. But specific blood tests for chronic diarrhea are kind of case by case. I would say a few that are, pretty accessible, obviously TTG for celiac disease. Some patients, if they have had, a concern for bile acid diarrhea, sending off a 7C4 can be helpful in certain cases. But beyond that, you probably don't have to chase, certain, peptide secreting tumor hormones unless there is something very unique about that case. We'll skip this slide. All right, so utility of imaging, utility of procedures. So when it comes to imaging, they can be helpful dependent on if there's a certain pathology that you're concerned about. So steatorrhea or inflammatory diarrhea are probably the two most common ones. All right, so with steatorrhea, usually how this plays out in practice is someone's seen their PCP for chronic diarrhea, they've got an elastase, it's low, they get sent over to us about, oh, does this patient have, EPI? And that's where it can be a little challenging. Okay, does this patient really have risk factors for, pancreatic insufficiency? Or are they more likely to have maybe some mucosal disease or inflammation in their proximal small bowel, and that is leading to a, decreased elastase? And so, my practice is, yeah, you can have somebody get a 72-hour fecal fat, but I would say I see less, chronic pancreatitis or exocrine pancreatic insufficiency as opposed to someone who has celiac disease or SIBO. So my suggestion is, well, let me get an MRCP. I'm going to feel more comfortable that this patient doesn't have anything going on with their pancreas. And then I can focus my efforts on, whether it's SIBO or celiac disease, a little bit, which are the more likely conditions. And then most often that's going to solve both of these issues. Inflammatory diarrhea, depending on where they are in terms of their workup, potentially getting imaging for Crohn's or UC can be helpful. What is the role of scoping? Doing a colonoscopy with biopsies is always going to be very helpful. It's going to have greater yield than doing a sigmoidoscopy. And we'll talk about different biopsy strategies on the next slide. Doing an upper endoscopy should also be considered, especially if someone's had unexplained steatorrhea. Again, taking biopsies of the proximal small bowel is helpful, not only for celiac disease, but some of the more atypical conditions, tropical sprue, Whipple's disease. You can see other toxicities from different medications. And so there are a lot of pathologies that can impact the, duodenum, which can lead to diarrhea. And so potentially sampling that area if it hasn't been done before is important. When it comes to biopsies, so when you're in a scope, where should you sample? What should you sample? So usually you don't have to take routine biopsies of the TI. What I would encourage people to do is if someone does have chronic diarrhea is to at least pop into the TI, just make sure things look okay. Obviously, if there's someone that I'm worried about, maybe IBD, or someone's already had imaging and there was a concern for enteritis, I usually will take samples just to make sure that there isn't anything concerning going on. I've definitely in fellowship have picked up a few cases of neuroendocrine tumors or carcinoid sitting in the TI, and so just something practice-wise is that getting in there and at least intubating 5-10 centimeters, just making sure things look okay is helpful. Biopsies for microscopic colitis, this is probably one of the more common diarrhea conditions you're going to see. And so making sure you take biopsies throughout the whole colon. And so the big thing to know is microscopic colitis can be patchy. And so you want to take, biopsies from the right colon, transverse colon, descending, and sigmoid, just 2 bites from each side. And then that way you feel pretty good that you had a good representation. Duodenal biopsies, like I mentioned, for certain pathologies. And then right now, there's no good role for doing like a balloon enteroscopy to take biopsies or sample for chronic diarrhea. Obviously, if there's a concern on imaging, there may be an indication, but in general, this is not something you're going to jump to. The last part here is what is the role of physiologic and microbiome testing? And so this kind of goes into, okay, how much workup do we do for, say, carbohydrate malabsorption, whether it's sucrose testing, fructose testing, someone has SIBO, someone has bile acid diarrhea, someone has EPI. I think it's going to be plus or minus. I definitely get patients that have had workup elsewhere, or they've had, more commonly, they've seen like a naturopath or functional medicine physician, and then they end up getting these non-validated FDA studies, and, everything is like right down the middle or weakly positive, weakly negative. And it is one of those things that you have to tell patients that, okay, my suspicion for, so-and-so pathology is high or low. We can go a few different ways. One is to get diagnostic testing and further workup. The other is maybe treat and use that as our diagnostic strategy. And based on your improvement, then decide if you need to do testing afterwards. And you can see all of these are kind of 2B, 2C recommendations. And so it's not wrong if someone has a suspicion for SIBO that you empirically will treat with rifaximin and see if they get better, or rifaximin and neomycin. Conversely, if someone is like, very hell-bent about getting tested first, then, sending for Trio Smart breath testing is something, I would recommend. Same thing with bile acid malabsorption. Most patients, if there's a strong suspicion for bile acid diarrhea, I'll treat. But definitely, I use the Mayo Clinic 7C4 send out test. Very easy. If you just type in on Google, just 7C4, there's a code that goes with that test. And then in the miscellaneous send out lab test, you just put in that code, and there really isn't anything to do from our end. It's a simple blood test. They go to the lab, get it done, and then you get the result within a couple of weeks. And then when it comes to pancreatic testing, everyone's going to be different. And, I encourage talking with the advanced guys too, when you see them in clinic about, what to do about a concern for EPI. In general, for my clinic, I end up seeing patients that have already either had a low elastase, or that might be part of the workup. I typically will not get a 72-hour fecal fat off the get-go. Like I said, I'm more about getting the MRCP and just feeling good about the pancreas. But again, there's nothing wrong with following up an elastase with a 72-hour fecal fat. I think the big thing to know, especially for general GI clinic, is that anything that affects small bowel mucosa can cause a low elastase. And because there is so much SIBO, so much gut dysbiosis that's going on, is that you really want to make sure that SIBO is off the table before you start maybe going down the route, okay, about, oh, do I put this patient on Creon? The last best clinical practice, and I think it's something just to keep in mind, not only for diarrhea, but any diagnosis that we see in GI clinic, is if, you do the initial workup and things are not improving, just take a step back. If you were in Vegas, what's the most likely, thing that you're going to bet on? And again, in general GI clinic, if someone comes in with reflux or abdominal pain, you should be betting on acid reflux and peptic ulcer disease before you're betting on anything else. And then same thing with, loose stools or diarrhea, you need to be thinking, okay, if you ruled out the most common things, IBS diarrhea or something in the medication, something in diet is something that is much more likely to be going on than some, weird, secretory tumor. So just something to keep in mind if things are not improving the way you want. All right, and so the final kind of 5 or 10 minutes will be kind of focused on a few different diagnoses that we see. I would say IBS diarrhea and microscopic colitis, you definitely have to get good at both of these. IBS, a lot of people are worried about it or scared about, okay, there's so many things going on. I would say it's actually pretty easy once you get good at teasing out the kind of questions that rule out the easier diagnoses that we had brought up earlier. And then once you can get an idea about, okay, is this someone we're thinking IBS? Then on this kind of flow chart, you can kind of tackle, okay, is this someone I can manage conservatively with, fiber supplementation or diet changes? Or is this somebody that I really have to go full court press? And then the other big part with IBS diarrhea is trying to tease out what is their most bothersome symptoms. So, I'll always ask the fellow when you're staffing is, what's the most bothersome thing for this patient? Patients are coming in and they're complaining of their loose stools, they're complaining of bloating, they're complaining of abdominal pain, and this has been going on years, and they expect you to cure this on the first visit. Well, that's kind of, those expectations can be challenging. This has taken many years to develop, and it's going to take a little time to get better. But asking what is the one thing that is bothering you most and affecting your quality of life, then you can start focusing, okay, we're going to try to target all of these, but our first approach to getting you feeling better is your abdominal pain or your loose stools. And that might impact, okay, is this someone I'm more likely to go to a TCA first, or is this somebody I'm going to be thinking about, rifaximin or Vyberzi first? And so we'll go over the potential treatments that you need to get comfortable with. So this is from the AGA guidelines about, what to do with IBS diarrhea. We're going to focus on the first three. So the AGA recommends that you can do eloxatiline, you can do rifaximin, and you can do allosetron as different managements for IBS diarrhea. There's a little bit lower evidence when it comes to how to best implement loperamide or TCAs or antispasmodics. And I'll go over kind of my approach as we go through these next few slides. So eloxatiline, also known as Vyberzi, this is a minimally absorbed, both mixed opioid receptor agonist and antagonist. It comes in two doses. For IBS diarrhea, it's at a 100 milligrams BID. If someone for some reason cannot tolerate it, then 75 BID is the dosing. The big thing to note, you can't use it in someone that's had a gall bladder surgery or someone that is actively drinking alcohol. I would say this is the medication to get comfortable with. I have had so much success going to Vyberzi, especially for a maintenance medication. Most of us are going to go with rifaximin as our first choice, and we'll go, talk about that next. But for those people that have ongoing symptoms, they haven't got a complete response to rifaximin, they probably need something long term. This medication, for the most part, is very safe. I've really never had anyone that said they couldn't tolerate it. And as long as they don't have one of those contraindications, then it's something that, I would encourage you to get used to or at least try because, you can't treat everyone with rifaximin. The big thing to also note with Vyberzi is that it has a much better impact for loose stools and global IBS symptoms in general, but it has less of an impact on abdominal pain. And so that's why on the last part, we're asking, is it pain? Is it bloating? Is it loose stools? What is the most bothersome thing for you? Because if they're complaining of pain and then they happen to have some bloating and loose stools, then that patient, I'm thinking a little more about going with rifaximin, and if it doesn't help, then probably going to TCA a little bit sooner. If it's more about I have a little bit of pain, but I'm more worried about my, stools, then Vyberzi might be a better choice. And then you can supplement with, say, like Bentyl or hyoscyamine as more of a as needed approach from the pain aspect. Rifaximin, obviously, we all get comfortable with this. It's a non-absorbable oral antibiotic, has activity against both gram-negatives and gram-positive bacteria. It's FDA approved at 550 TID for 14 days. Make sure when you're in clinic, you're not doing the kind of hepatic encephalopathy dosing. The big thing to note with rifaximin is you need to go 2 times. And so a lot of patients, they'll take rifaximin once and maybe they got a little bit of relief, but not great relief. The big thing to know and what the guidelines recommend is you should do 2 courses before getting an idea if someone is responding or not responding. Usually what I'll tell patients is take rifaximin, it's a 2-week course, wait 2 weeks, and then send me a my chart. And if you're feeling perfectly great, that's awesome. Then we're kind of home free. But if someone is only a little bit better or didn't get much relief, don't lose kind of, that you are not going to get better. We'll do a second course and then we'll revisit and then we'll go from there. And so that's the biggest takeaway when it comes to using rifaximin. The last medication you need to know about is allosetron. I will admit I've only used this a few times, mostly because I've had much more success with the first 2 medications. But allosetron's a selective serotonin antagonist, has both central and peripheral mediated mechanisms of actions. The big thing to note with this medication is you do need to know the side effects and the risks that come with this. So it had been approved for IBS-D in women back in 2000, but then it was recalled because of serious adverse effects, namely ischemic colitis and then really bad constipation. Later on, it was kind of reintroduced by the FDA that it could be used in severe IBS-D in women. Again, this is an option for us, especially if someone has kind of failed the typical medications. But I think for us, when it comes to kind of managing the risk benefits of certain medications and side effects, I have probably encouraged using Vyberzi instead of elacestrant as that maybe second choice after rifaximin. Well, lastly, jump into microscopic colitis. So big thing to know, you have to know the drugs that cause this condition. This is going to show up on your boards. This is going to show up in clinical practice. You know, a lot of patients are on several of these medications, aspirin, PPI, famotidine. They're taking NSAIDs for their chronic pain. They're on SSRIs. And so it's not necessarily you have to stop these, but just recognizing, okay, if they're on these medications and they've been on them for, months to years, it's just something that is definitely on the table when it comes to the differential. So as we know, microscopic colitis comes in two types, lymphocytic colitis and collagenous colitis. For the fellows, definitely get comfortable at being able to tease out a pathology slide and then kind of deciding what the next steps are, both in terms of diagnosis, but also in terms of treatment strategies. And so this algorithm is very helpful if someone is on one of those aforementioned medications. If they can, try to stop it. So if they're taking NSAIDs or if they just happen to be, taking a PPI and they don't really have reflux or a reason to need to be on the medication, then trying to stop it is very helpful. If the symptoms are very mild, you may get away with using fiber supplementation or loperamide, but most patients, by the time they see you, they've been having symptoms for a while. You do the colonoscopy, it has microscopic colitis. Usually what we'll do is stop the medication if possible, and then try to treat with budesonide. And usually that's a taper of 9 milligrams BID, then 6 BID, then 3 BID. Most patients, I would say, will respond very well to budesonide. I think the big thing is, and we'll talk about it, is if someone has a relapse in their symptoms, what do you do next? And, the guidelines will actually say is to go back to budesonide. And, for patients, if they notice that, hey, I feel great on 9, feel great on 6, so-so on 3, and then my symptoms come back, that might be somebody that you go back on 3 milligrams a little bit longer and then try to see if there's anything that you can do from a fiber side or loperamide, something else to augment the budesonide that maybe long-term that you can come off. Definitely, there are going to be some patients that you'll have to think about more, biologics or systemic steroids, but in general, most patients will get by with budesonide. And this kind of echoes what the AGA guidelines recommend is that, budesonide over nothing is what it's recommended for inducing clinical remission. And then budesonide is favored over mesalamine for inducing clinical remission. And then recommendation 9 is mostly that if someone has recurrence of symptoms, is to go back to budesonide. Like we talked about previously, making sure you take biopsies throughout the colon is very important. The other thing to note, microscopic colitis can run with celiac disease or an elevated TTG. So if you have someone that has, known celiac disease, they're on gluten-free diet, and they are doing well, and say there's, TTG is coming down, but it's still not completely resolved, and they're having loose stools, this might be somebody you want to do a colonoscopy on to see if they potentially have microscopic colitis that's contributing to symptoms. These are just some ACG questions. The main thing here is someone has remission or someone got remission with budesonide. Now their symptoms come back. What do? You're going to go back to budesonide. This question, and you're going to get a lot of this on the boards. You just get chunks of paragraphs, and then they have microscopic colitis, and they're going to be asking about treatment strategies. The name of the game, especially when it comes to questioning, is you want to stop the offending agent, cut the head off the snake. And so stopping PPI, stopping NSAIDs is usually the first approach. Last slide here, bile acid diarrhea. I would say, this is just something to keep in mind. We often will not do the diagnostic testing that commonly. Yes, you can do a 7C4, but the big thing to note is, has someone had any small bowel pathology, whether TI resection or small bowel Crohn's? Have they had, SIBO, or have they had their gallbladder removed. So just something to keep in mind when it comes to your differential. Treatment strategies, just know you have three different treatments: cholestyramine, cholestyramine, and clocevilam. In general, cholestyramine is not well tolerated. It can have nausea, vomiting. The more common thing is practically it's very hard to take with other medications. Cholestyramine is a little bit less so than cholestyramine, but it's very similar in terms of the side effect profile. I would say clocevilam is probably the easiest one for patients to tolerate, and it's something that you can start off with a low dose and then kind of up titrate the total. Again, bile acid diarrhea can run hand in hand with other things, and that's one thing we didn't touch upon too much is that just like with, say, constipation, there can be multiple things at play. And that's why trying to think about, patients globally about, okay, yeah, this patient may have post-infectious IBS, but there also might be a dietary component. There might be a certain medication that's driving things. And so trying to optimize each of these aspects can pretty much get you the result you're hoping for, rather than just kind of, anchoring yourself to one condition. So with that, I think that's all I had, but more than happy to take any questions or comments or anything about kind of like approach the diarrhea, both in clinic or